And now moving on, ladies and gentlemen, we're going to have our very first panel discussion on the topic Smart Digital Health Mapping of the States in India. Post-COVID-19, digital health technology has penetrated large parts of urban as well as the rural parts of India. There are government digital health initiatives as well as by the private companies that are working towards the accessibilities of better healthcare through various new digital platforms. However, the issue of accessibility and awareness amongst regions becomes important to ensure the success of these initiatives and schemes. Our very first session will bring together the relevant stakeholders to discuss the impact of digital health schemes as well as other digital health platforms, their implementation, their impact on each state benefiting common people, and identify the opportunities, prospects, as well as the challenges of inclusion and accessibility for the growth of digital health ecosystems in different states of the country. Ladies and gentlemen, to begin with our very first panel discussion, allow me to invite upon the stage our moderator of the session, Mr. Prabhat Sinha, Director, Public and Government Affairs, Boehringer, Ingelheim, India. We can do better with the round of applause, ladies and gentlemen. It is just the beginning of the morning and I need all the energy for the entire day summit. I would also like to invite upon stage our esteemed panelists for our very first panel discussion. Mr. Naveen Kumar, IAS, Special Secretary, Department of Health, Medical and Family Welfare, Government of Andhra Pradesh. Dr. Heera Lal, IAS, Additional Health Mission Director, Government of Uttar Pradesh, who would be joining us virtually. And we also have Dr. K. Madan Gopal, Senior Consultant, Health, Niti Ayog. And Mr. Neeraj Gupta, Founder and CEO, Genes to Me. I can hear the round of applause only from the members of the first table. How about, yeah, that is much better. And now I hand over the floor to the moderator of the session.
Good morning, everyone. And so first of all, today is a day for two things we remember, that this second digital summit is happening, and today is also a World Standards Day and also World Dessert Day. So don't forget to eat some desserts during the lunch. And so I think after a wonderful, a session which gave us a vision about the National Digital Health Mission and a lot of highways. So I think today we will also use two highways to go to UP and also Andhra Pradesh, where a lot of these policies we see going executed. And that's why I have two panelists. One, a very senior administrative officer from UP, who will be, I think, Heera sir will be joining us virtually. And Mr. Naveen Kumar from AP, who also have worked in UP. So one state which is new, another state which is a state which is known for its scale. We also have Mr. Madan sir from Niti Ayog, where you see all these cross-functional things happen at this center. And also we have Neeraj ji from Genes to Health, and we know how diagnostics plays the first step role in the healthcare. So a very esteemed panel. And so what I'll do, I know Madan sir, you have to go a little early, so I'll start with you. Now, once we heard about this entire vision of using digital, as Dr. R.S. Sharma said, is a means, it is not an end. It's a tool, but ultimately it's the health of our people and how we optimally use digital as a tool. Now, you talk a lot about equity, you talk about accessibility. Now, how you see a lot of these platforms, mediums, what we create, when it comes to equity in healthcare, reaching out to the last mile, and also plugging and play at the across the country. What is your vision? How you see this is happening?
Thank you very much. Thank you for taking me as first of your panelists. So I thought that you would be starting in the digital age on time. But as usual, we have to adopt the digital thing in a long way. That's one thing. But if you look at the healthcare scenario, healthcare services in the country, it's free for all. Each and every citizen, they can access healthcare. That means in the public institution, you, me, a lower income person, they can access the services there. There have been emphasis on improving the access, right from the board committee report, which talks about having a 2,000 bedded hospital in a community at the community level. Having said this, if you look at the progress of addressing the access issues, if you look at the demographic structure, it's still 60-40 differences there. That is 60% in the rural area and 40% in the urban, and the urbanization is happening. But the addressing the access issue, you see the how far we have access. Access include three things. One is provisioning of the healthcare. The second is utilization of the healthcare. And what is the status of the health which we have attained? These are the three things which determine the access of healthcare. One of the important things in the access, if you look at the public structure, because in India, after the liberalization during the 90s, you have seen a lot of private sector coming up. But before that, it was the government structure, and you see, you have a structure right up to a village level. Primary care, because being signatory of Alma-Ata Declaration and subsequent Millennium Development Goals, Sustainable Development Goals, and universal health coverage, we are having an approach that is comprehensive primary care approach. In that, we have created a structure through which preventive, promotive, and the other services are being provided. That's the first pillar of Ayushman Bharat, which we have been talking about. That means, if you look at the structure, at the section headquarters, that is, you are having sub-center, then you are having a primary health center, you are having community health center, then district hospital, medical college. That's the structure there in the system. That means a sub-center, which is now been upgraded as health and wellness center, that caters to a population of 3,000 to 5,000 population. It provides a range of services. Previously, we were providing 6 range of services. Now, people can access 12 range of services through this health and wellness center, that is upgraded sub-centers. The first contact with the medical officer is at the primary health care center. That kind of access things are there. When we were talking about the health and wellness center, when the sub-centers were upgraded to your health and wellness center, there was one component of using IT technology for leveraging or improving the more access to the services. That was the vision during that time. And it formed the first pillar of the Ayushman Bharat, that is the health and wellness center. So that's, apart from that, for increasing access, because creating infrastructure is a very long term and a cost intensive thing. And second thing, that any health event that is associated with some catastrophic cost attached to that. To address that thing, the second pillar, that is the Ayushman Bharat PMJ program, is there, which provides an assurance coverage to around 10 crore families. But if you look at the population which is covered, because many of the states, around 11 states, they have universalized the scheme, so that the financial catastrophe due to the health events, that is also taken care. Why the primary, preventive, promotive, and this services are being extended to the health and wellness center. And the financial catastrophe for this set of population is addressed through the PMJ program. After the COVID time, you see that there was a need for digitalization. So you are having the third pillar, that is Ayushman Bharat, the digital health mission. And there was a felt need for having impetus on focusing on the infrastructure. We are having the health infrastructure, PMAB, that is known as Ayushman Bharat Health Infrastructure Mission. So these are essentially four pillars of Ayushman Bharat, in which we are working, trying to see that how the access issues are addressed, how the healthcare is then made more affordable, how the catastrophic events leading to the expenditure of the people that have been taken care. Regarding the access, the question which you have shared earlier, regarding the access, these are all manned by people. If you look at the health and wellness center, you are having a mid-level service provider there, who is known as community health officer. He's essentially from the nursing background, and he would be, each person would be there. At the primary health center, you are having a medical officer. And at the community health center, the first level where the specialist services are available. That means for 100 villages or 80 to 120 villages, you will be having a specialist care with 4 specialized services, which depending on the population norms, you are having first referral unit, which provides emergency medical obstetric care and the other emergency care. But at that section level, connecting the section to the villages, we are having community health volunteers who will be helping the community to access the services of the system so that the access issues, as I mentioned, that provisioning we have done, but utilization of that services have been affected by your ASHA workers, accredited social health volunteers, active workers. So you see the utilization is also this. After the access and the provisioning, access and the utilization happens, you see the goals of the healthcare which are to be attained. So I will stop here. Thank you.
No, so I think you brought a very important point, which is ultimately at the primary level where, and it also connects with the other pillar of PMJY, which is Health and Wellness Center. And how do we connect and detect disease early so we don't have much load at the health center to treat. And I think this also takes me to Naveen sir, because a lot of Naveen things are happening in AP under your leadership. And if you can, and 2 things. One is recently we have heard that in AP you have started e-registry after making cancer a notifiable disease, and this is a breast cancer awareness month, and which is a wonderful initiative. So if you can talk a little bit about e-registry, and also we also heard about startups. We also heard that we need not to create everybody a new thing, because there is a lot that exists and a lot of young minds are doing that. So on these 2, what would be your sharing with the audience?
Thank you, Prabhat. What we try to do in what are we looking at? What is that digital health is trying to do in any state for that matter? You are a tool to give a healthcare to everybody, right? That's the agenda. It's not just when we start talking about digital health, we always think that digital health is the end of things. That is now not how you approach the healthcare. When you come to healthcare, although it's called digital health, digital is a tool for providing healthcare. That's actually how you look at it. So there are 2 examples which I wanted to speak about. One is that he was talking about cancer registry. If you look patterns of disease across the country, across the globe, there are only 4 diseases which constitute 65% of your disease burden, which is cancer, cardiology, diabetes, and hypertension. These are diseases which are preventable. Remember those one. These are diseases which are preventable. When you do an early detection, and treat them aggressively. For example, cancer, you detect early. I think many of us in this room would have had somebody who had suffered from cancer or not. So these are things which we can actually look at. So we have an advisor to the state government. We actually have a specific advisor to state government, Dr. Dignitaries. He's a US-based doctor who has been advising on comprehensive cancer care. When you ask me as an health secretary to Andhra government, you ask me what is the number of cancer cases in Andhra Pradesh, I would not be able to give you a number at all. I can only give you a range saying that it is somewhere between 55,000 to 70,000. I think Nitya also would agree with me on this one. Why is that we are not able to tell you this number accurately? Is that we do not have a system of registering the cases which are coming to us, right? So that the first and foremost thing which we ought to do in cancer is we need to know where are these cases coming from, what are the kinds of cases which are coming from, and it's more of a scientific study, right? So you need to understand this one. So that's the reason we made it as a notifiable disease. And if you had seen, there are only 2 successful cancer registries in the country. When I say successful in the sense, it is run by people with a lot of statistical mind. One is the Adyar Cancer Institute, and the other is the RCC at Trivandrum. Yes, the Tata Memorial also runs a very good, strong the cancer registry. So learning from them, we also knew that digital can be used to identify this one. We have AI, we have fuzzy logic, we have machine learning, which can be used to understand these registrations which are happening. For example, the diagnostic center also will register a case. The doctor number 1 who is treating the cancer for the cancer patient for the first time will register a case, and doctor number 2 will register, but the data will be different. When you see the data points, it will be very different. Somebody has to sit through the data points and see that these are diverse data points, and somebody has to have a mind. So if you sit through 70,000 data, 70,000 cases in a year, and for that the data points would be in millions. So we should use digital to, we should leverage digital to, digital technology to, do this analytics. That's why we are also looking at establishing India's first digital cancer registry. So AP government will, in fact, we have already gone through our Aragasri data to find out what kind of cancers come across which regions. If you ask me, I can, maybe not in a very bold tone, but I can always tell you, okay, these are the cancers which would come in the northern Andhra, which is more related to oral cancer. We have some GI cancer across the 2 districts of Andhra Pradesh, which is Krishna and Godavari. And these are the things insights which keep coming. So what happens when you have specific insight, when you talk about healthcare in the future, it is also, we talk about something called 2 parts in healthcare. When you talk about healthcare in the future, we talk about predictive care. When you talk about predictive care, you also think that how can you go, reach before it starts. I think that's the future of everybody sitting in this. What the lessons we learned from COVID is, how can we predict that something will go wrong and start building on it, not after you get hospitalized, right? So that's something, the biggest lessons we learned from COVID. Second would be precision medicine. And this would become very, very important given, I think if we are talking about cancer, there is something which is also, lurking in the background, which is called antimicrobial resistance, which would be the next big killer. I don't know how many of you are aware of it. The excessive use of antibiotics will lead to AMR. So these are things which are upcoming. So there are 2 things which would help the digital technology, and the use of digital technology in healthcare would be to create a bigger space for predictive care and also the precision medicine. And when I talked about NCD care, there is what is NCD care? We all take supplements, we take some medicines on a daily basis. One of the protocols which you need to take care of yourself when you have a non-communicable disease like diabetes or something, adherence to the medical protocol. So there could be digital follow-ups, and that is how. And home care will increase. I think when you talk about the healthcare continuum, home care is going to increase. You're already seeing it. There are services which are coming in the digital. I think there are startups which are already started providing Ola doctors. I think I heard of this name. Some Ola doctors or Uber doctors would start very soon, right? So that is one part. So there's a lot of need for then expanding the continuum, the healthcare continuum. Second, you talked about startups. I thought it's a big topic again. I was told that the current CEO of Roche is the diagnostic head. So this is a very strong message which is coming across the digital healthcare spectrum, is that the digital diagnostic is going to be the most important part. Why is it? There is a connection. As I explained to you, there is a connection between the NCD care. So you need, in fact, I'm told that there is specialized, I see a couple of people wearing a watch with, it also counts whether your cardio activity is in line with what you think or not. And there are some belts, I think I'm told when you go to the gym, you're supposed to wear it, because you know that there are incidents which are happening for excessive stress or whatever you think. So digital diagnostics, not just medical wearables. We are also talking about, consumer wearables. It's like day-to-day life, you will be starting doing wearables. And this space is going to expand. If you ask me, what is that new thing which will happen in the next 10 years of the digital technology? It's not the IT part. It would be more of the diagnostic part involving a lot of IT, data analytics. And this would help us building that what we think as predictive, because when you look at resources, human resources, all limited. I'll specifically use a use case which I always talk about it. I have a digital ECG machine which I can carry to any rural part of Andhra Pradesh. I can pick those signals, I can register that person and record those digital ECG. Now these ECG, normal doctor, when you talk about an untrained doctor, will not be able to pick that murmur, the small murmur which is making sense. Only a cardiologist would be able to pick that murmur. So when you look at it, these ECGs which are digitally recorded can be read by a system which is AI or ML. And this system, they can pull out those 200, 300 records which has to be only seen by a cardiologist. In fact, it could be this algorithm, or we can also send it to 2 cardiologists to make it doubly sure. So these are the ways. And when he is making it and when he is confirming, again, the system is learning. So your AI system it keeps on learning. It becomes even better. And it's a typical case study which we are looking at, right? So there are more examples which could come out. And I'm very sure even the lab records can be read by systems and tell, okay, this is how we should. And I'm very sure the digital diagnostic space will change the way we look at the rural healthcare. I'm talking about a rural healthcare. We have talked about how do we connect that rural healthcare. It is not about the people in the cities. It is not about the people who are affluent. When we talked about COVID, we talked about the whole of government, whole of society approach. When we talk about it again and again, we talk about whole of society, whole of government approach. The healthcare must always have this in mind when you are doing something for the public. It is the whole of government and the whole of society approach to take everything to the last man who is standing or the last woman who is there in the rural setup. That's my opening remarks.
Very rightly said. And I think the piece you talked about, that continuum of care, the precision medicine, and also the diagnostic, which we'll hear more from Neeraj ji later on. But I think continuing from AP, let me go to the state of Uttar Pradesh. And since Dr. Heera Lal sir is there, so, and you know, he recently has written a wonderful book, which is going to be a bestseller, I believe. And one of the things that he talked about in his book, and he has been talking, is on governance. Now, in a state like UP, which is bigger than many of the countries, how do you see many of these initiatives which is happening, and also at primary care level, what Mr. Madan sir just shared, training and equipping your health workforce under NHM in UP? What is your vision? How do you see state is gearing to that?
Okay, thank you to our IHW, and I would like to welcome at the outset all the esteemed speakers and audiences.
Sir, currently we are not getting your audio. Now I think.
I'm audible?
Yes, now you're audible.
Okay, so sorry, I wanted to join physically, but it is my bad luck because of sudden some assignments for today. I could not join physically. So as we all know, COVID-19 pandemic destabilized the world economic order. That is the negative side, and its effect will be felt in coming many more years as we are getting news daily. But India's health ecosystem has witnessed a mature transformation in the past 2 years. It has brought down the resistance drastically to adopt technology in healthcare sector. Why? Reason is very simple. During the pandemic, it was the technology which, through technology, we connected, communicated, and cooperated in order to save our life. So it is the technology which alone helped a lot, among other many things. So digitization has opened a new avenue for positive transformation in health sector. What they are, adoption of digital technology is growing at a fast rate, one thing, and new platform for online consultation is growing and increasing day by day, which we know all. And data analytics and data mining is used for the ramping up of healthcare infrastructure and capacity building, which was not in practice before pandemic. So these are the present positive transformation due to pandemic. We always talk about the negative things of any pandemic, but this pandemic has given this positive thing, particularly for the healthcare sector. As regards future healthcare transformation, digital record, we are going to record everything digitally in different schemes, and what will be the outcome of that, it will be the real enabler at every level, at worker level, at doctors level, at medical stakeholders level. And this digitized healthcare data will help in facilitate for better treatment, for better delivery of healthcare services in remote areas where we are not able to approach, where we are not able to provide these services in spite of our desire. So that will be a great help through digital technology. Second thing, this digitized healthcare data and record will help in minimizing the time of the diagnosis. The time of diagnosis matters. So that will be minimized and it will help in different ways. And there will be a drastic cost reduction in the treatment. So that is the future outcome of the digitization, for which we are in the process to get it done in the field. One thing I would like to add more, prevention is better than cure. By now, we always talk about the cure. But in the last 5 years, we are changing gradually and slowly our focus from cure to prevention. Because nobody wants to get ill. Everybody wants that we be healthy and happy. And to be that, prevention is one option which is ignored by now, but it is getting our focus. We are reducing our attention from cure and shifting that attention for the prevention. In this, the technology and digitization of healthcare will be a great help to us. As regards UP, we all know UP is the biggest state, vast state, and Government of India is monitoring. Even today at 5 o'clock, we are going to be monitored on the progress of the PM Abhim. They have allotted money, they have given all the details to implement in the states. So to monitor the status of the progress, we are continuously monitored by the Government of India so that the required infrastructure, required HR should be in place in coming 5 years to meet our dream, what we are dreaming to provide adequate medical health services to the remote area or the remotest area of the rural. And I hope the way we are moving, the way we are working, the way things are being monitored, it is going to happen and we will realize our dream. So this I want to say. Thank you.
Thank you, sir. And you are also a proponent of model village, Adarsh villager, I think, with integrating some of the digital tools where it is needed more. I think that was a great suggestion, and I'll please be on the line because I'll also open the floor for a few questions. So please be there. Okay. Now this takes me, so we have heard a lot about digital diagnostics and prevention is cure, especially with the chronic disease, right diagnosis, and also with all these highways and sideways being made. How do you integrate diagnostics, and how do you see ABDM and NHA opening doors for diagnostics in this country and ultimately impacting our lives?
Thank you very much for, first of all, having me and James to me on the platform. It's really a very encouraging scenario for us to share what we have been able to contribute. I think technology plays a very significant role and goes hand in hand with the digital. Any platform we kind of integrate with, and I think technology, but we do have to also realize that 60 to 70% of the Indian population lives in the rural areas and the tier 3 cities, and where it's a very remote, resource limited, and and for the healthcare resources as well as for the diagnostic services. And we also heard about the involvement of artificial intelligence in the healthcare, in the digital health platform. But I think this is still far from reality because it's a great technology, it's a future of the technology, I would say. But still, we have a huge journey to go through with a lot of data mapping and correlating with that clinical history of the patients, and then implement that at a rural level. And then at the same time, also make it versatile for technology to correlate with that platform. So, but one thing which we also got as a positive side of the outcome of the COVID pandemic was the infrastructure that has been able to build across the country at the very most remote areas of the country. I think one of these, the most important technology that has today developed is the real-time PCR technology. So we all did real-time PCR test across the country and this is the only technology which we have a trained manpower and the infrastructure at the every road across the country, I would say, and at the rural level to the urban level. And so how we can leverage this whole network of the resource which we have built during the pandemic, which has proven that the molecular diagnostics was the center stage of handling any advanced based pandemic kind of situation. And at the same time, every state in India has its own set of challenges for various health conditions. Like Dr. Naveen also mentioned about various situations where they have been doing extremely good job with oncology, and so as so many different other burdens. But India is one of the most diverse country genetically across the world, and studying that, how these genes and how genetic diversity we have in our different states can lead to a lot of information. So one of the most important mandate I think we should do using the technology access is genetic mapping across different states. So we, for example, one of the genetic disorder which is very prominent is sickle cell and beta thalassemia. Sickle cell, you will be surprised to hear, in several states in India, it is prevalent to more than 55% of prevalence. And that is also preventable. We heard various initiatives which are around preventable healthcare. So, and how we can leverage this technology infrastructure which is now available. So we can implement variety of solutions, right from cancer to sickle cell, diabetes, or tuberculosis, another women health based program like HPV or HBV, HIV. So these all can be tested at a cost effective manner at the rural level with the installed infrastructure available today in our country. So this is something which is, I think, the way forward for all the integration of molecular diagnostics, genetic based diagnostics, and your different states with the mapping of the infrastructure availability. Another thing which we heard about today was in the preventive and precision medicine. Today, genetics has that kind of a huge insight. And we at Genes to Me today, we have launched a very big solution called Genome Kundli. So we talk about genetic based horoscope of the every individual, healthy individual. And if that information is available, it gives you a lot of insights about a genetic makeup of every different diverse population. And it gives you information about which medicines, which drugs will work for which individual, and they can be treated with a lot more preciseness and accuracy. So thank you.
So thank you. And I think before, sir, you go, I'll take one comment and I'll go to all the panel members. While we talk about a lot of promises in future, currently, if you have to put one challenge, sitting at Niti Aayog, when you see these digital initiatives getting rolled out, what is that one biggest challenge you see currently everybody is grappling with?
One of the biggest challenge which we have noticed during the COVID times and now also, when the guidelines were released, so a lot of telemedicine consultations have happened. But opening up and having teleconsultation is one thing, and connecting it with the hospital so that a continuum of care is ensured, that's another thing. That's a very severe challenge because these teleconsultations are not resulting into the continuum of care, and how to address that thing. Second thing is how to ensure teleconsultations or telemedicine facilities 24/7 specialists, how to aggregate all these small players so that the person need not to invest, saying that the person, if somebody is in Gujarat and the person is in Assam, he want to talk in Gujarati, he can connect to that. That kind of aggregation network should be created. That's the biggest challenge. How to do that, we have to see. And biggest challenge is that which I have mentioned, that how to ensure that the continuum happens after that. Continuum of care is the biggest challenge, including other things. Thank you very much. I have to leave because I have to be.
Yeah, I know. So give a big round of applause to Dr. Madan Gopalji, and thank you for your presence, sir. So I'll continue with the same question, Naveenji, to you also, that when it comes to challenges, currently a lot of future things happening. Our health workforce, our system is also evolving day by day. What you see a challenge when it comes to executing and getting this implemented in the states?
Oh, see, first of all, we learned a lot of things from the COVID pandemic, right? So are we able to institutionalize those learnings? I'll put it very simply, right? I don't know how many of you have a very clear memory of how this pandemic started. So there was a lot of disbalances or imbalances, which you call, in the way we approach across the country. So I would call this pandemic in a way has made it a level playing ground. If you see, if you read any state's, response to the wave 2 or the wave 3, there was a streamlined activities. They will talk about a command control center. They talk about their telemedicine. In fact, the AP experience has been like this. What is that? What is the actual, if you talk to me in terms of administrator, what is the pandemic problem? The problem is to supply logistic, have good hospital facilities, and the right people get right treatment. That's exactly what you look at, right? So when you do that, how do we do it? We do it through a triaging. Many of you would have, I don't know whether you've been to an COVID care center, you would, first you go to a triaging facility. Since AP was bifurcated from Telangana, we did not have any good tertiary care centers across AP. How did we approach this particular matter? We started doing an home triaging, in fact. So the reason we have so many health records in our ABDM is that only. We started going home to home with a tab, finding out what that person, does he have a fever or not. So the entire fever analysis or fever study was done on a tab, on a digital form. And there are 3 options when you do a fever survey, right? So when you do a fever survey, we have 3 options. One is whether that he should continue or she should continue to be in the home only. Second would be whether he or she should be sent to a COVID care center, which is the next level of it. Third, with excessive comorbidity, should he or she should be referred to an hospital. Doing this, we were able to do I would not call it amazing work, but I would call it as a good work with logistic management. We could, if you actually go, there were people who were squatting in, I would not call them squatting. There were people who were occupying beds because they had that fear that something might happen to them. But the right people also, there were people who actually were in need of the bed. So we were able to, bring a balance about this one using this triaging. I think triaging was one of the most things which helped at the end of your wave 2 triaging was very, very important, right? So that's more important. So this is how a digital technology was used. When I started my conversation also, I spoke about how a technology was an enabler or a tool to bring about this healthcare. There are lessons we have learned and we should not forget. That's most important. When you ask me, I think that should be the lessons which we learned should not be forgotten. And when we see a new kind of disease burden happening, these lessons can be used extensively. For example, I also head this AP State AIDS Control Society. This is one extensive system. There is a tracking. They also find whether you are adhering to your medical protocols. These are lessons which are already available in the in the health setup. So can we replicate these protocols, the lessons, the failures which we came across into a newer adaptation to what we look at using technology? Or what is enabler? When we talk about technology, it brings down the cost, right? When you talk about transactional cost, digital should bring the transactional cost. I think he was mentioning, Neeraj was talking about it. I would be able to give an cost effective. That is the word he used when he made his statement, right? Cost effective. Can we bring cost effective treatment? When we talk about healthcare, there is one important concept which we talk about is out of pocket expenditure. How many of us can afford to have a proper, I'm told if there is an ailment in a family, I'm talking about a moderately around the borderline. After an ailment, they actually step back into the below poverty line, right? So there are breadwinners who step back into, if the breadwinner is a cancer patient, what would happen to the family? So these are the questions. I think somebody has also asked me, are we looking at prevention? Prevention is the key for healthcare. When I talk about it very clearly, that is it's not about putting on extra hospital. We should look at how can we reduce that extra hospital. So that should be the agenda for setting up the healthcare continuum in the future. So these are lessons we have learned. There are very strong lessons. I think we should be happy that we learned very good lessons in the healthcare management during COVID. These lessons should be put on in the other aspects of the healthcare also, which would help us. I think it has been a very good leveling ground. So I think that's the challenge. I would not call it as challenge. That's an opportunity. I think that's an opportunity. It is there in our eyes. We should use it. All of you sitting here should use this opportunity to build this nation. Thank you.
Yeah. And I think COVID itself, I think, became one of the enabler to, kind of go for all these digital tools in a faster manner. So if I go back again, Dr. Heera sir, जब हम challenge की बात करते हैं in UP again, if I have to ask you कि number one challenge when it comes to adapting these digital tools, वो क्या challenge आपको लगता है UP जैसे state में, which is the number one challenge है?
Challenge is the implementation being vast and wide. We have got huge amount of the fund from the GOI, okay, and resources are same. So right now we are facing this challenge, how to spend that money quality wide and to meet out the expectations of the government of India with the same resources, because suddenly we cannot increase our management. So that is the biggest challenge in our system, and which I think.
Very rightly put.
I've been a special secretary UP also. So see, if you look at UP in the last, I think Heera ji bhi uska part hai. Yeah. So the way, again, I was also part of, we started this UP journey somewhere in 18. The management of drug supplies has been streamlined. That's one big achievement which UP has already done. If you see, in fact, I'm told that the UP Medical Supply Corporation is one of those agencies which is very popular across the country also. And it did a pretty good work during the COVID management. Second, UP also has a very strong health strengthening system. So we talk about, I think a lot of good work has happened in UP in the last maybe 6-7 years to strengthen what the healthcare facilities would do. I think the only problem, I think even Heera ji was correctly mentioning, it's a scale. When you look at UP, whatever you do is like a drop in the ocean. But I think the drop is getting bigger and bigger now. I think it's becoming clear to see the effects of what is happening in healthcare in UP.
Very rightly put. So Neeraj ji, again, coming back to you, when we talk about challenge, if one challenge you have to highlight, especially this whole integration of diagnostics with existing NDHM or with NHA, what is that one challenge that you would like to highlight?
I think one of the biggest is the adoption of technologies at the rural level. So, and since we have these entire digital platform, which is associated with all the ASHA workers to PHC teams. So how can we integrate training programs for implementation of such diagnostic technologies so that it can be implemented at a much more scalable methods, and then adoption of various solutions which can be used for the grassroots level screening programs for various health conditions. Just like one of the initiatives which is ongoing on a very big scale in India is the tuberculosis. And that's something which is already at its very upscale. And so similarly, we can adopt a lot of many other different technology essays or different parameters which can be adopted for similar kind of programs. Another challenge which we learned during the pandemic time was how we can make technologies much faster so that we all waited in lines for 48 hours to 3 days to get our RT-PCR report, which should not take more than a couple of hours in general. So how we can make this available as a technology at a grassroots level. So at Genes2Me, we were one of the largest contributor in the RT-PCR solution across the country. We are almost 1 in every 5 tests in India for RT-PCR. We are proud that Genes2Me was behind that as a solution provider. But beyond that, what we have learned during that time, how we can make it faster, how we can logistically transfer these solutions to a grassroots level, which is itself challenged with logistics. So we developed room temperature stable reagents, which were unconventionally minus 20 degrees and storage conditions required for storage as well as transportation, which has become a biggest challenge in the rural level, which was not equipped to handle such kind of solutions. So we developed, and the second solution which we developed was how we can bring a molecular technology accessible at a grassroots level. So that was another challenge which could do. So we developed a portable PCR, which is smallest of its kind and the most powerful solution, which can do the same RT-PCR at a grassroots level in just 30 minutes with no skilled trained manpower required to run that platform. And it has got an automated reporting solution, so that can be integrated much faster and easier for carrying out any national screening initiatives.
Good. So I'm just conscious of time, and it will not be a justice if you don't get a chance to ask questions to the panelists here. So floor is open. Please introduce yourself and also be specific to whom you want to be asking your question, and be little precise while you ask your question. So anyone? Yes, please.
Thank you all panel members for taking us through the entire journey of the country which is there. Myself, Dipankar, I belong to Bewell Health Tech, which is a pioneer in creating contactless selfie monitoring tool. So my question is that we talked a lot about rural adoptions, training, and not awareness, another aspect. Do you see this is more towards a behavioral aspect, or it is a lack of infrastructures or digital presence or digital divide? What exactly it stands for us?
So you have directed your question to whom?
We can take it from.
Okay.
See, I think we also live in, I have this thing, frog in the well, right? We believe that what we see is all that we see, right? So this is a case with every country. It's not just, you answered all the questions. In fact, I don't even have to answer your question. All your points are the same. If you ask me, it is digital infrastructure. There's a gaps in infrastructure. There's also awareness. I'm putting it like this, okay? How many schemes do you know that it is happening in health to you? You're also well aware, right? So that is the thing. It's always been this across the governance. It's not, I'm not, bluffing you off, but across the governance, these are the issues which will keep coming again and again. What we do as an administrator is to fill in these gaps. How do I fill in awareness? How do I bring in the gaps in digital infrastructure? In fact, we were able to fill in 40,000 posts in AP in the last 3 months. Identify those gaps. Even then, we are not getting specialists and super specialties specialists to go to the rural setup. How do we, that's the reason I was talking about that use case which I was talking about, right? Can I be able to put a cardiologist in a center like Padero, which is like 3 hours from Vizag? So how do I solve questions? So that's where you guys are sitting here. So you have to come with solutions. We work together, bring in technology as an enabler to solve these problems. So the infrastructure, when we talked about 5G, in fact, you remember the same thing which the Honorable Prime Minister saw it. We were trying to do it. The case study which I explained was exactly what he saw. There was an ambulance going there somewhere in the rural setup using 5G technology to pick out those ECG it is readily transmitting to some place and some doctor saw it. These would work. We would, I would see that the way we look at healthcare would be different. There is a lab technician who would go there, record details and send it to an expert somewhere, take his report, medicate or give medical advice, and maybe multiple advice. There's a scale of telemedicine which can happen maybe from an lab technician, you go to an MO or maybe to super specialties. So the way we think the conventional healthcare system would change, I think it has already changed. The COVID was a very good example. We also would look at centralized command center. In fact, there is a startup called Carkinos, which is executing cancer care through using a digital technology. There is an integrated command center for this one. So there are scope for improvement. There are a lot of things which would happen. We keep striving to be there better. My closing remarks was this one only. It is the whole of society approach we will adopt to take the benefit of healthcare to every single citizen whom he or she should benefit from. That's all.
So we will be able to take one question before I hand it over for the next session. So yes, sir, from that table.
This is my question, Mr. Naveen. My name is Dr. Pinak, and I run a digital healthcare fund called Health Quad. We invest in very interesting technology-backed healthcare opportunities which are trying to solve for the real-world issues of Indian healthcare. My question here is that we encourage our companies to take their digital solutions to the rural markets of India, the extra urban and rural markets of India. At the same time, we know that it will not be possible completely if it was left only to the companies to do that because of the lack of experience, expertise, as well as the on-ground infrastructure to do that. And hence, they have to do it in conjunction with the government at some point in time. My problem is that their interaction with governments is not really frictionless. And that is one of the major impediments for companies to actually leverage the government infrastructure to be able to create the digital networks that one would really love to see. And that has a repercussion on their funding also, because funders look at government revenues as one lumpy, unpredictable. There is a delay in payment cycles. All of that. How is the government looking at solving some of these issues?
See, it's an easy question to answer for me. So when you look at, I've been in this IT space for some time, right? So I was there somewhere in 14 when we wrote the first startup policy for UP. I think somewhere in 14 we had the first IT startup policy for UP government. You would not believe, many people when we wrote up this policy, they asked, UP is coming with a startup policy. In fact, if you also go across Noida, which is next door, because of the UP's electronic manufacturing policy, it is the hub of electronic manufacturing policy. I'm talking about, I've been a part of it for a long time. So the answers you asked, how did CoWIN win the CoWIN app? They were able to give usable data for others to use. There is a ready-made change. I do not know whether you have seen the government scape in the last 10 years and what is now, right? The startup policy itself talks about collaboration with the, partners who are startups. If you see, there have been changes in the procurement policy to use or you let startups to participate in tenders. That is also very, very important. I think that's something, a big change. Yes, we are evolving. You might not think we have not evolved the way you think we should evolve. And I'm very sure I'm very, very proud when I say this one. Our country has evolved faster than any other country in this space. I think I'm very proud about it. I cannot even mince my words saying this one. I put it very clearly that we have evolved very strongly on this forte. It is something which I'm very, very proud of. Yes, we evolve, and there is a change of mindset. You talk about payments. There's also a system called PFMS. Do you know that we are also, the government has implemented single nodal accounts where the payments can be tracked? Yes, we have done it. You see, it's a continuous change which has been happening. What we were some time back, what we are different. and it is progressive. That's very important. We have been progressing, and I'm very sure that we are progressing faster than any other body in this world.
I think there cannot be a better end to what you said. Is that hope, is this progression and this accelerated innovation that is happening, and I think government is embracing that, allowing these partnerships to go. I know, sir, you have a question, but if you can just be very precise. Yes.
From Key Healthcare Private Limited, I have a question to Mr. Naveen Kumar. The question is, in metros, the healthcare is not a problem. But what about the rural area where the BPL family or the farmers, those who can't afford the treatment, like, the cancer and oncology treatment? What about them? What the government official they are trying to save many lives? Thank you.
Again, an easy question for me. The expenditure we spent on cancer in AP is 400 crores in medical insurance. And 175 crores has been spent on this CM, the Honorable CM Relief Fund. That the total is what? 575 crores. Where do you think this money has gone? The money has gone for the people who are what you call BPL and all. So the government is already doing it. See, that's the problem when we sit in a hall like this, right? When we talk about it, we do not know. I wrote a post, I think I recently wrote a post. What you see, what happened during COVID is that there was a person knocking your door asking whether you are doing well or not. It is what exactly happens in the rural setup. The ASHA worker goes to every doorstep to find out whether that person is doing well or not. There are registers in, Anganwadis, which is a 13-1 column register, which records what that pregnant lady is going through every trimester. There is a system which is there on the ground. We do not see it. It doesn't mean that just because we do not see it, that doesn't exist. So that is what I can say.
Sure. So thank you with this. Thank you to each one of the panelists. Also, Dr. Yadav, who joined us virtually from Lucknow, and also to ISW Council to create this platform to bring these very good examples from states which give us a lot of hope. So thank you, and over to you.
And with this, ladies and gentlemen, we have come to the end of our very first panel discussion where we were discussing the smart digital health mapping of states in India. And we would like to commemorate the occasion. And I request the esteemed panelists to kindly be upon the stage. We would like to present them a small token of appreciation, for which may I invite Mr. Kamal Narayan once again to kindly come up on the stage and present a small token of appreciation to our esteemed panelists and the moderator. We'd like to present a memento to Mr. Prabhat Sinha. Mr. Prabhat Sinha, who is the moderator of our session. We'd also like to felicitate Mr. Naveen Kumar, IAS. And Mr. Neeraj Gupta, founder and CEO of Princeton. Thank you all.